Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. Today we are joined by radiation oncologist Akila Viswanathan, professor and interim director of radiation oncology and molecular radiation sciences, and director of the National Capital Region's Johns Hopkins Radiation Oncology and Molecular Radiation Sciences. Dr. Viswanathan, you are directing the opening of the Johns Hopkins Proton Beam Center. Please give us an insight into the impactful therapy and some of its uses.
Thanks so much, Lillie. It's great to be here with you today. We know that cancer is a major problem for healthcare and for patients that we see in the Sidney Kimmel Cancer Center. 1 in 2 of the population will get cancer in his or her lifetime, and there are 100 or more different cancer types. So although people like to talk about cancer as a generic word, it really boils down to where the cancer is, where the cancer may or may not have spread to, and what type of cancer it is. Because even in one particular structure, there can be many different cells that could cause or turn into cancer over time. I think it's important to realize that this is not a one-size-fits-all disease.
How very true. And I think that is a frustration for scientists and researchers, but it also is important that patients and consumers understand that one kind of cancer is not the same as another kind. And even within one specific organ site, like breast cancer, it has many different derivatives. Again, it's not one size fits all. So what types of cancers can proton beam therapy treat?
Proton beam therapy is used in many different types of cancers. The most commonly accepted and used is pediatric cancers. So we know that children have significant long-term consequences when normal tissue receives radiation. And so the goal of proton therapy is to treat significantly less normal tissue. And what that means for children is that less of, say, the normal brain is radiated, and that can spare things like IQ points in the future, or less normal spine or bone receives radiation, so that may impact future growth. So all of these pediatric cancers are really great for proton therapy. In addition, we do also recommend proton therapy for adults, and adults that have, you can imagine, sensitive tissues close to the tumor are those that are best suited for proton therapy. We talk about brain tumors or brain cancers where there may be a normal structure that's related to hearing or a normal structure that's related to seeing, and those are the kinds of tumors that are best suited. There have been many recent studies that have looked at tumors that are, say, close to the heart, whether it be lung cancers or esophageal cancers or breast cancers, where data is currently being accumulated to show that there might be a benefit, but that takes a long time, many decades to show that radiating less of the heart causes less long-term risk of, say, a heart attack.
So it makes me think about the Hippocratic Oath that we all took of do no harm, that you're really focusing on let's only zap what needs zapping and try to protect other structures. Now, I also think about whether it be young adults and certainly for children, for those that we are hoping will become survivors, to be able to preserve their fertility, that one day maybe they'll be able to have their own children when they're grown up, or it could be a young adult with a type of cancer that, again, he or she may say, in the future, I'm hoping to start a family. So we don't want to zap things that may prevent that from being able to happen in a fairly easy way, because that's usually one of the life goals that people will think about.
Exactly.
Can you give some examples of types of cancers? That you mentioned about breast, I think about prostate, certainly brain. Are there others that would really stick out in the minds of those that are listening to this broadcast, other solid organ tumors, for example?
Absolutely. Head and neck cancers are in the area of the mouth and the throat, which are also close to critical spine and other neurologic structures, as well as things that affect digestion. So taste is affected by salivary glands receiving radiation. We see significant numbers of patients that discuss or want to know more about proton therapy because they want to spare their normal taste function over time. Head and neck cancers are often referred for proton therapy. There's another whole category of patients that are treated for cancers of any sort, but that they had radiation one time. And now with proton beam therapy, because of its precise targeting, there is a category called re-irradiation in a radiated field, giving proton therapy where photon therapy may have been used before. And so that really is not just one disease type, it can be all disease types. But again, we talk about proton therapy for brain tumors, so lung cancers, rare tumors that can occur in the chest, like thymomas, breast cancers, prostate cancer, other gynecologic cancers to some extent, but less so than, say, sarcomas, which are muscle tumors that can arise anywhere in the body, but generally are around the bony tissues and bony structures, so away from the central organs.
So this is really opening up a new opportunity for patients, as you mentioned, who have had radiation in the past. And of course, in the past, we would have said, we cannot re-radiate you. I live and breathe in the world of breast cancer, and so if a woman has had a lumpectomy followed by radiation and has a local recurrence in that breast, our standard of care has been that we now need to do a mastectomy, even though the local recurrence of a tumor may be quite small. So this opens that door for hopefully us to still be able to save her breast and to not see this as now I have to have a much bigger surgery that I was hoping I could certainly avoid. When we look at radiation, and I think it's important that we do talk a little bit about what I'm going to describe as late effects. People are accustomed to side effects while they're receiving the treatment, and for those side effects to linger for some months after the treatment, fatigue being one that is commonly an issue. But late effects is something that isn't spoken about very much, and I think it's worth a while to educate our audience. What do we mean by late effects, and how late can that effect in fact happen?
We all wish that treatments could be given and be curative without there being any adverse effect of the treatment. And as we all know, there's a give and take, back and forth that occurs with treatments. And sometimes patients get through without having any, what we call toxicity from treatment, but it is expected that there are both acute and late effects. And the acute effects depend on the site of the body treated, but generally can include things like feeling tired during the treatment. And in some people, that can take months to resolve. So even though the treatment itself is a few weeks, that side effect, which is a result of the immune system kicking in and some of the repair that's occurring in the body as a result of getting the treatment, it can take months to recover one's full strength. I think there's also, depending again on the site, a range of side effects that occur during treatment. Most of them resolve, but there's always a risk, particularly as we just talked about re-irradiation, for example, that some of those side effects may persist for a long time. I treat women that have gynecologic cancers, and it's very common during treatment for women to get a little bit of diarrhea or to have a little bit of change in the way that they urinate, which we call cystitis. And those can generally be managed during treatment. In a few patients, those symptoms persist and are quite uncomfortable. And so we manage those side effects over time. But what we ideally don't want to see, but we are prepared to take care of, are patients that have effects, say, with rectal problems, diarrhea or bleeding from the rectum long term, or they may have a side effect that's related to the nerve damage that causes a pain or a symptom. Like, for example, with chemotherapy, one of the effects that occurs in gynecologic cancer patients a lot is called neuropathy, which means numbness, but it can be also a tingling sensation in the toes or in the hands. And in some women, it can take months or years to recover from that. And in general, the vast majority do recover, but there are always a handful of people that don't fully recover.
And that certainly impacts quality of life in such a significant way. It's just not dealing with knowing that you have a side effect. It's also, how does this side effect impact your quality of life on a day-to-day basis? It's also then a chronic reminder, gee, I had cancer. And we do try to help patients put that behind them so they can move forward and stay on track for their life goals and what brings them joy and plan a future. Let's talk a little bit about the Johns Hopkins Proton Center. It's going to be opening in the fall of 2019, so very soon. Tell us, where is it going to be located and some more details about it.
Absolutely. So at Sibley Memorial Hospital, which is a Johns Hopkins hospital in Washington, D.C., we'll have a full-fledged Proton Center. It's its own building that is on the side of the main hospital, and 3 stories. It has 3 full rotational gantries. That means that the machine will move 360 degrees around the patient, providing quick and efficient treatment. So the patient doesn't have to move during the treatment, nor do we have to move the machine to get around the patient. So really, the speed of treatment will be faster than any other type of gantry would be, and we also will have a very novel set of imaging devices that we can use during treatment to help us align the patient most precisely, to ensure that we're doing the highest level of precision medicine and precision radiation treatment possible.
And does that involve a physicist?
Absolutely. We always have physicists on hand at many levels, but from the time someone comes in the door and gets a consult at the Proton Center, they will meet a physician, and that physician works with a team that includes what we call a dosimetrist, which is a physicist that does calculations for the treatment plan, and also move from the consult to getting what's called a simulation, which is a series of scans. Now, in the Proton Center, we'll have both a dual energy CT, which is a cutting-edge machine for CT scanning, as well as a 1.5 Tesla MR unit that will allow us to do very cutting-edge MR imaging to align both the CT and the MR to deliver accurate proton therapy. And the physicists coordinate the imaging as well as the treatment planning that occurs once the imaging is done.
For patients that have had radiation in the past, they would be familiar with the simulation experience. They also would be familiar with laying on a table, all right, and having radiation. How many seconds of radiation might someone be getting through proton therapy?
It's not really seconds. We're still talking in terms of minutes.
Okay.
But with the full 360 gantry, we anticipate that it will cut down the treatment time by a third.
Wonderful.
So instead of 30 to 40 minutes of treatment, we're talking ideally something like 20 minutes of treatment.
Okay. When you think about coming frequently, getting in and getting out, sounds like it'll take more time for them to get their clothes off and back on than it will to actually have the treatment, which is really wonderful. How much of a pinpoint can proton therapy do? So, for example, something smaller than a nickel, or would it need to be as big as a quarter in order for proton therapy to bullseye the spot?
That's a great question. Historically, proton therapy has, for the past decade, used a very, what we call a broad beam and what's called passive scattering. So the beam itself, when it was spread over what's called the Bragg peak, which is this fine line that we want to say proton therapy stops at, instead, the older machines forced there to be a smear or spread of the proton dose. Now we'll have at Sibley what's called pencil beam scanning, and a spot size that is just a few millimeters in size. And that pencil beam precision means that we're treating millimeter by millimeter the tumor in layers with this pencil beam. If you can imagine coloring on a flat surface and going back and forth to the shape of a tumor, and now you lay on millimeter by millimeter, each layer colored in, if you will, that is the technology that we'll have at Sibley, this pencil beam scanning.
That's a good descriptor, and I like the word pencil because it really does tell us about a pencil point when we're drawing a line that's about a millimeter. A lot of people don't know or understand millimeters from centimeters and such, but using pencil lead is a great analogy for it. Will the center be treating both children as well as adults?
Yes, we have a great collaboration with Children's National Medical Center in Washington, D.C., and we'll be treating children in the Washington, D.C. area, as well as the regional area, of course, including Johns Hopkins patients from Baltimore, but then also the wider region, which includes many states that are in our region, nationally and internationally. So we anticipate children being able to use this benefit and the resource of proton therapy at Sibley to great effect.
Now today, let's say a patient having, I'm going to call it traditional external beam radiation, might be receiving treatment for 6 weeks, or if I think about prostate cancer, maybe longer than that. Will the number of treatments still be the same, or will that also be less?
Over time, there are research trials that are looking at varying the number of treatments given. So standard treatment requires a certain number of treatments, whether it be 30 treatments, say, for prostate, or 25 treatments for GYN or gynecologic cancers. Newer treatment regimens may be just 5 treatments. With a much more precise targeting, we can give fewer treatments with a higher dose with each treatment. So some of this is going to be available on clinical trials that we expect to open at the Proton Center. Every patient, we hope, will be eligible and enrolled on a clinical trial, whether it be a prospective randomized trial or a registry trial. We anticipate that there will be a study that we would like to enroll every patient on.
Let's talk a little bit more about clinical trials, because for some individuals that may be a foreign term, or they may have some myths about clinical trials. What we're talking about is really innovative therapy. Proton therapy became what it is today because of people in the past having participated in a clinical trial, comparing the traditional external beam to this proton therapy, and now being able to validate that this works very well and can spare other organs and tissue from getting zapped and doing harm to it. You mentioned that there may also be some registry trials, and this would involve literally registering someone that then would be followed long term so that we can do some comparative outcome, clinical outcome measurements with those individuals to see, did they develop certain side effects? Were they the same side effects they would have gotten having, I'm now going to call it the older method of radiation therapy? I am a big fan of clinical trials. I participate in clinical trials with each of my cancers, and as a 27-year survivor, I still look for clinical trials related to survivorship. I'm hoping that those of you that are listening to this podcast today, when you think about a clinical trial, that you realize that those who have gone before us and participated in a clinical trial have paved the way for new and innovative treatments that are now the evidence-based medicine that we, in fact, use today. When I look back and think about radiation therapy, I went to nursing school a very long time ago. I actually graduated 45 years ago. I remember cobalt radiation, which was pretty daggone horrific. Even having it go through someone's body, like a bullet with an exit hole through their back, as if we did, in fact, shoot them. And now we're able to pinpoint exactly how we want radiation delivered to a very precise spot measured in millimeters and spare those other organs around it and no longer have to go stand somebody up against a wall and go all the way through their body in order to radiate something that is in that pathway. I know patients still alive who've had the cobalt radiation, and they are so excited to hear about this proton therapy. They said, wow, have we come an incredibly long ways? And I said, yes. And it also tells us, too, that radiation is very important, that it isn't something that we say, oh, you don't need radiation anymore. In talking in general about radiation, surgery we think of as local treatment. We're going to remove the cancer, physically remove it, or remove as much of it as we can. Chemotherapy is thought of as systemic treatment, treating the entire body. Hormonal therapy also is, immunotherapy is, targeted therapies are. But radiation therapy is also a local treatment. Sometimes I had a patient say, oh, it's the cleaner upper. And I thought that is also a great analogy of having had surgery to remove the tumor, but there may be some rogue cells left behind that cannot be seen on any scan. And we want to make sure that they are not left alive to survive and multiply and divide and regrow this tumor back. What percentage of patients in general, particularly those with solid organ tumors, do you think today are receiving radiation?
We know that about 40% of all cancer patients in the United States receive radiation. And radiation has two purposes: local therapy and what we call regional therapy. Local therapy can either be in patients that have a tumor that doesn't fit the bill for surgery. So for some reason, either the patient can't handle surgery or the tumor has grown in a way in a local spot where surgery would cause more harm than good. So radiation's used instead of surgery. The other type of treatment, what we call regional therapy, is when we think that the cancer that may have already been removed may have spread into the network around the cancer. And so that kind of spider-like web that's surrounding the cancer is infiltrated by single cells that the surgeon just doesn't see, and you can't take out all of that normal tissue because the patient would be left with horrendous side effects. So we do use radiation to clean up that regional area of lymph nodes and surrounding normal tissue, what I sometimes call the tumor bed or the operative bed, where the cancer, the bulk of it was removed, but we still want to clean up all those cells in that regional zone.
So this is really exciting. I love it when Johns Hopkins embraces new therapies that are going to directly, in a positive way, impact so many cancer patients, and not just adults, but also children who we hope survive their cancer and grow up and have quality of life as an adult as well. So this fall, we will be opening this particular Proton Therapy Center. It will be located at Sibley, one of our Johns Hopkins affiliates. And though obviously I'm hoping that listeners won't need us, if you do need us, we are there for you. Let me also mention that for those that may not have transportation to go back and forth from their home to radiation therapy, there are advocacy organizations that we have access to for all of our Johns Hopkins affiliates that provide free transportation. So we don't want that to ever be a barrier as to why someone doesn't get the treatment that they need and certainly do deserve. Thank you so much for joining us today. I look forward to the opening and hearing more about it.
Appreciate it. Thank you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lillie Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from Biosense Webster and Boston Scientific that support our podcast series, Insights That Matter. For more information about a woman's journey, visit our website, hopkinsmedicine.org/a woman's journey. And like us on Facebook and Twitter. Until next time, stay well.